Welcome back to 50 Studies Every Neonatologist Should Know. I'm Dr. Adnan Hadid, and today we're looking at one of the most influential respiratory trials in modern neonatology, the SUPPORT trial, published in 2010. SUPPORT asked a deceptively simple question. When an extremely preterm baby is born, do we reach straight for the breathing tube and surfactant, the way we'd been trained to do? Or can we start gently with CPAP, continuous positive airway pressure, and only intubate the babies who actually need it? This is a study that helped shift delivery room practice around the world. So let's get into it. Here's how the authors themselves framed their conclusion. Notice how measured the language is. They don't say CPAP is better, and they don't say surfactant is obsolete. They say CPAP deserves consideration as an alternative. That restraint matters, and you'll see why as we walk through the numbers. This was a trial that changed practice not by declaring a clear winner, but by showing that a gentler approach was a safe and reasonable place to start. Let's look at the precise question they set out to answer. Let's frame this in PICO terms. The population is the smallest, most fragile babies we care for, born between 24 and 27 weeks. The intervention is starting these babies on CPAP right in the delivery room, giving surfactant only to those who genuinely need it. The comparison is what was then the conventional approach. Intubate everyone and give surfactant within the first hour. And the primary outcome is a composite: death or bronchopulmonary dysplasia, chronic lung disease, measured at 36 weeks post-menstrual age. Combining death and BPD into one outcome is deliberate, because a therapy that reduces lung disease but increases death wouldn't be a real win. With the question set, let's talk about why it needed asking. To understand why SUPPORT mattered, you have to understand the dilemma neonatologists faced. Surfactant is one of the great success stories of our field. It transformed survival for premature babies with respiratory distress. But to give it the traditional way, you have to intubate, and mechanical ventilation is not gentle. Positive pressure breaths delivered to immature lungs can trigger inflammation and injury that contributes to bronchopulmonary dysplasia. So clinicians were caught between two goods: give surfactant early or avoid the ventilator. Observational studies suggested you might be able to start babies on CPAP and reserve intubation for those who failed, getting much of the benefit while sparing many infants the tube. SUPPORT was designed to test that head-to-head. Let's see how they built it. SUPPORT was a randomized controlled trial run across more than 20 sites in the NICHD Neonatal Research Network in the United States. It enrolled 1,316 infants, which is a large trial for this population. One design feature is critical. It used a 2x2 factorial design. That means each baby was randomized on two separate questions at once: CPAP versus intubation, and a higher versus lower oxygen saturation target. We're focused on the respiratory arm today. The oxygen targeting results are a story of their own, covered in the next study. And note the timing of randomization. It happened before birth, by antenatal consent. Hold on to that detail, because it comes back when we discuss the trial's limitations. The trial was unmasked, meaning caregivers knew which arm each baby was in. Now, who exactly got enrolled? The trial targeted the babies where the question is hardest: extremely preterm infants from 24 to 27 weeks, with a mean gestation right around 26 weeks. They were consented antenatally, before birth. On the exclusion side, babies with known malformations were out, as were those where a decision had been made not to provide full resuscitation. And critically, babies below 24 weeks were excluded, because an earlier feasibility trial had shown that essentially all of those most immature infants required intubation in the delivery room anyway. Keep that boundary in mind. It means SUPPORT tells us a lot about the 24 to 27 week baby, but very little about the most immature infants we now sometimes resuscitate. Let's look at exactly what each arm received. Here are the two strategies side by side. In the CPAP arm, babies were placed on CPAP right in the delivery room and kept on it through admission to the NICU. They only got surfactant if they actually needed intubation for resuscitation, and if so, within the first hour. They could still be intubated later in the NICU if they met standard criteria, but the whole philosophy was start gentle, escalate only when forced to. In the surfactant arm, babies were intubated in the delivery room as a matter of course, given surfactant within the hour, and kept on the ventilator until they met extubation criteria. One subtle but important point, the extubation thresholds differed between the two arms, which is the kind of design choice that can blur the comparison. We'll come back to that. Now, what were they measuring?
The primary outcome was that composite we discussed, death or bronchopulmonary dysplasia at 36 weeks. Pairing them matters because either one alone can mislead. The selected secondary outcomes were the complications that haunt extremely preterm infants: pneumothorax, which is an air leak from overdistended lungs, IVH, intraventricular hemorrhage, bleeding in the brain, and ROP, retinopathy of prematurity, the eye disease linked to oxygen exposure. These secondaries are how you check whether a gentler respiratory strategy is buying lung benefit at some hidden cost elsewhere. So what did they find?
Here are the headline numbers, and this is where support gets interesting. On the primary outcome, death or BPD, the rate was 47.8% in the CPAP group versus 51% with routine intubation. The relative risk was 0.95. The confidence interval crossed 1, and the p-value was 0.30. In plain terms, no statistically significant difference. CPAP didn't beat intubation on the main outcome. But look at the secondary results. Babies on CPAP were more often alive and off the ventilator by day 7, and they spent about 3 fewer days on mechanical ventilation, both statistically significant. So the gentler strategy didn't harm these babies, and it reduced ventilator exposure. That's the real takeaway. CPAP is a safe place to start. Let me show you that contrast visually. This is the picture worth holding in your mind. The two bars are remarkably close: 47.8% for CPAP, 51% for routine intubation. Visually, you can see there's no meaningful gap, and the relative risk box on the right tells the statistical story: 0.95, with a confidence interval that runs from 0.85 to 1.05. Because that interval crosses 1, the result is not statistically significant. The honest interpretation is not CPAP wins. It's CPAP is non-inferior on the outcome that matters most while sparing babies ventilator time. That's a more useful conclusion than a flashy win would have been. Now, let's be critical about what could have muddied these results.
No trial is perfect, and support has real weaknesses you should be able to name. First, it was unmasked. Caregivers knew which arm each baby was in, which opens the door to performance and detection bias in how babies were managed and assessed. Second, and this is important, there was substantial crossover and dilution. About a third of the COP babies ended up intubated during resuscitation anyway, and surfactant delivery was inconsistent between arms. That blurs the contrast and could have hidden a true difference. Third, because randomization happened before birth by antenatal consent, the enrolled population was healthier than average. Mothers who consented had more antenatal steroids and better outcomes. And finally, generalizability is limited. Babies under 24 weeks were excluded, steroid use was very high, and COP technology has moved on since 2010. So what happened after support?
Support didn't stand alone. It was part of a wave. The Cone trial, published 2 years earlier, had already hinted in the same direction, though it didn't reach significance. Then, in 2013, a meta-analysis pooled 4 randomized trials, nearly 2,800 infants, and found a statistically significant benefit for delivery room CPAP on the combined outcome of death or BPD, relative risk 0.90. That pooled signal is what individual trials like support couldn't show on their own. On the strength of this evidence, major guidelines, the American Academy of Pediatrics and the European RDS guidelines, endorsed early CPAP with selective surfactant as a legitimate alternative to routine intubation. And the story keeps moving. The Optimist A trial in 2021 showed that less invasive surfactant, LISA, given to babies breathing on CPAP can reduce BPD even further. So let's land the plane on what this means at the bedside.
So here's the bottom line for your practice. First, starting an extremely preterm baby on CPAP in the delivery room is a safe alternative to reflexively intubating. You are not putting the baby at higher risk by trying the gentle route first. Second, on its own, support didn't show CPAP reducing death or chronic lung disease, but it did reduce time on the ventilator without increasing complications, and less ventilator exposure is a meaningful good. Third, when you pool support with its sibling trials, a genuine benefit emerges, which is why CPAP first has become standard practice in much of the world. And fourth, apply this where the evidence is strongest, the 24 to 27-week infant. For the most immature babies, the answer is far less settled. Let's give the last word to the trialist.
It's worth hearing directly from Neil Feiner, one of the trial's leaders, because his reflections sharpen two of the points we've made. On the left, he candidly acknowledges the selection problem we raised earlier. Because consent happened before birth, the enrolled babies were a healthier group. More antenatal steroids, better educated mothers, lower rates of death and severe brain injury than eligible babies who weren't enrolled. That's an honest admission about who these results truly apply to. On the right, he looks forward and points to LISA, less invasive surfactant administration, as the most promising next step, widely used in Europe but understudied in the US at the time. He also flags newer interfaces and high-flow cannula as open questions, especially for the smallest babies. It's a reminder that a landmark trial is a snapshot of a moving field. Let's close with the references.
And those are the key references behind today's discussion, anchored by the original 2010 New England Journal paper, plus the COIN trial, the 2013 meta-analysis that pooled the evidence together, the guideline statements, and the more recent Optimist A trial on less invasive surfactant. If you want to go deeper on any single thread, these are your starting points. Thanks for joining me for this study in the series. I'm Dr. Adnan Hadid, and I'll see you in the next one.